Okay, so welcome back from lunch. If you'd all like to take your seats, then we can commence the afternoon session. Lovely. Okay, can I welcome Dr. Steve Higgins? Okay, so Dr. Steve Higgins is coming up now. I'll let him introduce himself, but he's a clinical psychologist from the BEHÇET'S Centre in London. You just press next.
Okay.
Just remember the online audience. Don't wander too much.
I'll try not to wander too much. I'll try and get this right. Hello, everybody. Hi, I'm named Steve. I'm the psychologist in the London BEHÇET'S Centre. And I've got my presentation. Now, previous years with my presentation, I've really kept all the slides with us, and I've added a few slides at the end. The reason for that is I liked it to be cohesive, so that you can go through the slides on the YouTube and you can see all the different kind of parts of the lectures that we've done over the years, okay? I always start with this, our aim is for ordinary people like you who are living with Behçet's disease. I always emphasise ordinary, because that's what you are. You're ordinary people, and it's not you who's extraordinary. It's your circumstances that you find yourself in. And I think it's really important to really emphasise that, because many people come to the clinic feeling that they are extraordinary, very different, and somehow they can't cope with what's happening to them. And I'm here to say, we'll all be in the same boat as you are. Okay, you're ordinary people experiencing very different and extraordinary circumstances. Okay, so the first set of slides, I'll just kind of go through fairly as a summary. People who've been to previous presentations may remember some of these, so I won't go too much into them. First of all, the golden rules of clinical health psychology, when people come to see me, are, is the way you present, is it a function of the person's physical state? Is it something physical that's going on with them that's rendering them to feel and act in the way that they do? And if it's not that, is it their social environmental context? Before I start thinking about something that's inside your mind that we have to think about. Okay, and for the majority of people, it's actually a function of these two, physical state and the environment and social context that they live in, that's causing them to feel or experience psychological distress. Okay, so we'll look at a little bit at the experience of living with Behçet's, the mind-body relationship, and ways of helping. And the last few slides are the new slides that I'm going to go through with you. Okay, this is taking it back to the beginning. We are who we are. Really, how we've coped and been shaped by adversity and things in our life. The people around us, how they've treated us as when we were children, how we've grown up. And that really lays the foundation and the blueprint for how we carry ourselves in the world. Alongside that, with something like Behçet's, we have this kind of almost like, and I don't mean to be disrespectful, I say merry-go-round of the medical journey, in which there is a sense of often not being understood by medical professionals and people like me and the health systems. And people go round and round, often for years and years, and it is this often toxic cycle that really renders people, I think, psychologically unwell. Symptom to diagnosis delays. Well, we know since the Behçet's clinics have been set up that we've reduced that. But I think, and I may be wrong here, Professor Fortune can correct me, but I think prior to the clinics, it was about 13 years with symptom to diagnosis. That's a lot of life to live not knowing what's going on with you. And that sense of meeting professionals who are puzzled, who don't know, who don't believe you, can really, really render people into a very isolated place. They're often referred to people like me, psychologists and psychiatrists and counsellors, because they're often told that these things are functional, or they're in their head, or there's something wrong with their mind. It's not actually their body that's going on. And I put in some little quotes every now and then. I think this is a really powerful one, that not having your suffering recognised is a form of violence that people feel. They feel so excluded and isolated by these. So we get diagnosis, help and treatment, and then often that's great. There's mixed feelings, but often people feel quite pleased that they've had a diagnosis because for years and years they've had nothing. And then they find it's not a cure and they're having to live longer term with this condition. And often there's a slump in their well-being at that point because they realise, oh, this is going to go on and on and on, and I have to manage this long term. There's no fixes here. And alongside that, we have shattered dreams, lives that have changed, hopes that have been lost. I've often used the 5 stages of Kubler-Ross's grief model. It's a kind of linear model, which I don't like. And people who know me will know that I don't like this last box, the acceptance model. People go through a whole load of stages that they keep often repeatedly going through until Kubler-Ross would say acceptance. Well, I don't agree with acceptance. I would frame it more as acceptability, and that's something that can move around. Sometimes it's more acceptable, and other times it's actually not acceptable at all. You don't want it. You don't want to go near it. And I emphasise that because people will often feel that they are somehow failed. They haven't even grieved properly. They can't even do that. Well, I don't think that's right. It varies throughout one's life. These are just some of the quotes from people. You can read them at your leisure, who've talked about adjusting to live in the symptoms. Socialising, friends, work. Professor Fortune was talking about work earlier on. Sometimes work can be a real source of support, but more often than not, it's not. Often it's quite the opposite for people. And there's closeness that people can create for themselves. The masking that occurs. And I know you're all expert at masking. I've met so many of you now that I know you can do this. And the masking is there to protect yourself. But of course, it also renders you isolated and misunderstood because you get those comments all the time. You're looking well today. You look really good. But inside you're not. And they don't understand how much effort you have had to make in order for you to just appear ordinary. There's often this changed sense of who you are. The way you thought you were going to be, the way you thought life was going to play out for you. I include relationships and sexuality and intimacy. We know that there's lots of issues around this. People often feel body image issues. The BEHÇET'S itself can interfere with ulceration. And often people will keep it quiet. They don't say anything, even if sexual intimacy is painful for them. They'll often not tell other people. And it can engender feelings of shame, and avoidance of sexual experiences. And I like this quote by David Smale, who's a psychologist in Nottingham, I think, many years ago. And his understanding was, really from what I've said at the beginning, people will come to him and say, why am I so inadequate? Why cannot I control these or manage or these circumstances that I find myself in? And he says, it's not you that's inadequate, because you are ordinary. It's your circumstances that are doing it to you. They're the problem. So immediately with this introduction, I'm really casting a wider net away from individual psychology to the context that you're living within. I think this is really important. I discussed this a few years ago, which is really something that's very misunderstood, that there is, in terms of flaring and auto-inflammatory disease and autoimmune flaring, there are direct impacts on your behaviour, and your cognition and your emotional systems in your brain. There are, in fact, just ordinary processes that happen when people have infections or are ill. And we call this sickness behavior model, okay? And it's a whole range of different things that occur. And you will experience these: the tiredness, the fatigue, the lethargy, the excessive sleeping, the loss of appetite, reduction in self-care, the isolation that people get involved, the loss or the not wanting to or be motivated to go and do things, the heightened sensitivity of the pain network. So sometimes old pains, when you're flaring, will re-emerge. So pain can emerge all over your body. And people get very confused by this. Fear, and it's seen across a range of different conditions, as we see at the bottom. The other thing that's quite important is that lack of ability to concentrate. Well, actually, there's really good reasons why you have that. You call it brain fog, but it affects your mood. When you're in flare, the mood flattens. You have a flattened affect. You're not depressed. You're not sad. It's your brain mechanism that's making you flat. You have cognitive impairment. You can't process things. You can't organize things. Your memory recall's poor. And sometimes that can extend even when people are outside of obvious flaring. We've talked about pain perception. You have the worsening of comorbid pains. You've altered pain sensation. And you have this threshold of pain tolerance and sensitivity changes. So things that might not have been painful when you're not flaring are painful. Almost a bit like the fibromyalgic kind of sensations that people have. And then that fatigue that nags and gnaws at people in their everyday life. And even when people are managed on with the medications, often when I speak to them, they'll have chronic fatigue and chronic brain fog and chronic low mood. And what's really going on when I ask them is they still have small peripheral symptoms. So the BEHÇET'S is still trying to flare, so they'll have low-level symptoms. But because they've still got low-level activation, you're still going to get all of these types of psychological and cognitive symptoms. So people can have a long time, months, years even, with brain fog, pain sensitivity, and flat mood. Often people are put on things like antidepressants, which can help sometimes. More often than not with this kind of thing, they don't help. And then we get this, that's a kind of primary stuff. 5 minutes already, oh gosh, oh my God. I need about an hour, okay? And then you've got to make sense of it. And making sense of it means that people often question, why am I like this? What's going on for me? What's rendering me incapable of doing it? And also, you'll have, if you flip this one, sadness about their lives, fear about their future, and worry. So these things compound already a low mood that people have. Now, I'm going to flip through these ways of helping. The reason I'm going to do that, you can look at your leisure in the YouTube videos, okay? And I'm going to emphasize the first 2 points in my next couple of minutes. So I'm not going to go through these. You can go through at your leisure. The different ways that psychology helps individuals, so mindfulness and cognitive behavior therapy and trauma therapy and compassion-focused therapy. There's a whole load of this stuff that we do, and it can be very helpful. Okay, there's lots of them. And these are kind of book resources that you can go and have a look at if you want. They're self-help books, and they're quite helpful. And I use a lot of them. I kind of overarch this with values-based living, which is part of what we call acceptance and commitment therapy, so the happiness trap and full catastrophe living. And I think it broadens it a bit to your wider life, not just your individual psychology. Okay, but this is really what I want to think about for really the last couple of minutes, is individualism versus collectivism. Most of psychological therapies emphasize individualism. It's you who has to change. It's you who has to do things in your mind to change it, to make it better. But really, I'm thinking about collectivism and the idea of rootedness and the idea of belonging and the idea of reciprocity in your relationships with people. And it's really through this outward looking as opposed to inward looking that we find meaning and purpose in our lives. And I want to come two very simple kind of exercises that we do. I'm sure most people know about spoon theory, which is why I've used it. The idea that you have spoons of energy, but you don't know how much you have on any given day or any given time. And it really varies on the state of our health and the type of demands that are placed upon us. So you don't know what you can do and who you can give your time to. Now, people who work with me, often I'll use the 3 circles exercise. Dead simple. We've got in the middle is you, and then we've got the inner circle. We've got a kind of middle circle. Inner circle are your closest family, the people who love you, the people who support you, and the people you support, okay? People in the middle are friends, relatives, wider community. They care about you, but they're not quite so there for you. And then the wider circle are kind of your neighbours and more kind of acquaintances. And actually, outside the circle, you've got other people in the community. And what I find often is that people living with BEHÇET'S and other conditions like this will give their energy and their time to people who are not in their inner circle. It's very common that they'll be giving it to people who really are not so there for them. And I'm saying to you, I think you need to really rationalise this and really think about who you're giving your time and your limited, unknown energies to. And this is why I think we've got the gift of spoons. You could map this out yourself individually. It's very easy to do. Plot people where they are in your inner, outer and middle circles and think, who demands my time? And do they give it back to me in equal or reciprocal way? And if they don't, I'm saying to you, you really need to think about those relationships and how you are giving your time and energy away. And the gift of spoons really is, I would say, moving the time and energy that you give to people on the outer circles and giving them as a gift to the people in your inner circle. And what I hear all the time is that you never give it to the people who you love most and who love you most. You're always giving it to other people. The people who are closest to you are the ones who are often the ones you're fatigued with and tired with and unwell with. And I think the 3 circles is a way to give them a gift by preserving your energy from people in the outer circle and give it where you have it to those who actually care about you. Okay, that's really my take-home message today. So living with BEHÇET'S is really a summary. The things that we grow up influence us, including your immune systems. Okay, your developing immune system as a child will be affected by the way you've grown up. Symptoms in living without diagnosis, often for years, will also impact on you how you see yourself, but it will impact your immune system because you will be rendered isolated and you'll be rendered feeling that you are somehow not ordinary, somehow abnormal. The meaning and loss of around diagnosis, rebuilding and making room for things like BEHÇET'S disease, and reshaping, which is most of where psychology emphasises itself, reshaping your relationship with yourself. Well, I'm saying you need to look outward and reshape your relationship with those who love you and those who are around you in order for you to give them the gift of your time and your energy. Okay, that's really my take-home message today. Thank you so much.
I'd like to welcome up Professor Ali Jawad, consultant rheumatologist.
Well, thank you very much for inviting me to be with you today. I thought it's best to, we saw Hannah talking about collapsing a couple of vertebrae in her back. And so I thought, because a significant number of patients with BEHÇET'S take steroids. It's also their mobility gets impaired. And some of the medication does affect the bones. So looking after the bones is important. And in fact, if you look after your bones very well, you're in better health in general. That's me. Anyway, that's just the... So essentially, our bones are made up of calcium, which makes it strong, but also there is a lot of collagen to give the flexibility to the skeleton, to the bones in general. But so it's really, in a way, calcium and collagen. And we have two types of bones in our body. The spongy bones are in the skull, the pelvis, the vertebral column, but the strong bones are in a way in the limbs in general. But most bones contain a bit of this and a bit of that. In a way, the trabecular or the spongy bone, you could see why it is spongy, because it's really made up of a network. It's almost like a sponge. Exactly, it looks like a sponge, but with time, these trabeculae get thinner and thinner, and 20% of our skeleton is in fact made up of this spongy bone, and 80% is the one in the long bones. The spongy bone is the most metabolically active, and this is where the blood is formed. If you get infection, you get it in the spongy bone. If you get vitamin D deficiency, it's mainly the spongy bone. If you get cancer, it tends to go into the spongy bone. But most, and you could see it's always covered by a bit of the cortical bone, which is strong. You can see the difference between the spongy and you have to remember it is, and the cortical bone, as I said, is the one that is very dense and is metabolically less active. Now, the reason why I'm going to talk about bone cells, because every 10 years you've got a new skeleton. So our bones, they do change. Obviously, we're not talking about the first decade of life. It's from the third decade of life. And so every 6 months, 5% of your bone will be eaten out. You could say for 2 weeks. And then for the next 5.5 months, the body replaces what it has lost. And the reason it does that, I mean, I think I could see a lot of you are old enough to remember those iron bridges. They used to fall before they used steel to put them apart, because bone suffers from fatigue, and you have to change the bone. So that is important. So there are three types of cells. Well, this is the reserve, the osteocyte. But the osteoclasts, they work very hard, very quickly for 2 weeks, removing all this bone. But these poor osteoblasts, it takes them 5.5 months to replace what has been removed. And you can see how nasty they are. Look, they are really big. Look how many nuclei there are. And they have a brush. So they brush the area, and then they put some enzymes and really resorb the bone. Well, look, these osteoblasts, they're very tiny. They take a long time to replace what the osteoclasts have done. And the osteocytes, where do the osteoblasts come from? They come from osteocytes, and they live in these holes within the bone. Now, let me show you. So put that in perspective. Now, what do? Just press on that.
Human bone is remodeled throughout life in a process of self-renewal. On a continuing basis, existing bone is removed at multiple sites or resorbed, and new bone is formed. Peak bone mass is achieved between the ages of 25 and 35. After peak bone mass is achieved, the balance of bone formation and resorption shifts to favor resorption. With the onset of menopause, the rate of bone loss is accelerated for approximately 5 to 7 years. With a decrease in bone mineral density, there is an associated increase in the risk of fracture. At the tissue level, healthy trabecular bone appears as an interconnected lattice of plates and bars. In osteoporosis, thinning of trabecular bone eventually leads to a loss of connections between the trabecular plates. A microscopic look at osteoporotic trabecular bone reveals perforated plates and disconnected bars. Osteoporotic bone is subject to fracture with less stress than normal trabecular bone. Cortical bone, compact by nature, is also affected, and according to theoretical models, becomes more porous. Mineralization may be impaired as part of increased remodeling, resulting in weakened, injury-susceptible bone. Two cell types, osteoclasts and osteoblasts, are key factors in the bone remodeling process. During active remodeling, osteoclast precursors exit blood vessels and fuse together to form large cells called osteoclasts. These then attach to the bone surface to resorb bone matrix. This resorption involves the dissolving of calcium and phosphate and the enzymatic digestion of collagen and other protein within the matrix. Osteoblasts then enter the resorption cavity, where they deposit new bone matrix. Enough new bone matrix is formed and then mineralized to fill the resorption cavity. In healthy bone of a young adult, the active remodeling process at a single site lasts several months. Following the active remodeling phase, a resting phase occurs before a new remodeling cycle resumes. This resting phase can last several years in trabecular bone. At the start of the resting phase, the bone matrix is not yet fully mineralized. During the resting phase, secondary mineralization occurs. Menopause alters the bone remodeling process in several ways. On one hand, osteoclasts resorb more bone than osteoblasts build at the remodeling sites. Thus, osteoblasts incompletely fill the resorption pits. The result is a net loss of bone. In addition, the number of remodeling sites increases. There also tend to be more sites of freshly formed bone that are not fully mineralized. Consequently, over time, there develops a progressive decline in bone mass, and this is associated with an increased risk of fracture.
So I thought, did you see how nasty these osteoclasts are? Anyway, now this is really very important. If there are planners amongst you or ministers of health, this is how you plan and in a way for better bone health. You could see that that in fact up to the age of 28 we don't reach bone maturity. Bone maturity takes so it's not 18 or the voting age of 17 or 28, and then our bones stabilize from 28 to around 45, and then after that we begin to lose bone 1% a year. But in women there are two problems. There are only two problems with women. One is they never reach the peak bone mass that a man reaches. The second is the loss of ovarian function. And the third one is they don't have the muscle build that a man has. So in a way, when they fall, they are less likely to protect themselves. And people forget, especially doctors, that when we get older, we lose muscle mass as well. But because we can't measure muscle mass very easily, we tend to ignore it. But in fact, so in a way, you could see that this is why important that in a way, all children, teenagers, should really have adequate calcium and vitamin D in their diet That's the time when they shouldn't really be smoking or drinking too much alcohol. Keeping active is important. And then when we get older, it's important that we address the issue of bone loss. So that's really important. And you could see from the video that how these trabecularly thin and you get microfractures, and this is why you could easily squash that and you get a break. Now, this is really what you need to take. Everyone should follow this. These are really, in a way, the 7 golden rules. Have a healthy, balanced diet. We'll talk about that in a minute. Adequate calcium. The best way to take the calcium is within your diet. Vitamin D, quite often we do need vitamin D supplements once it is Greenwich Mean Time. You don't probably need it during a British summertime. Exercise, smoking, alcohol, and falls assessment for the older people. Just go through it. A nutrient-rich, healthy diet. Well, I think a small protein is very important. There is no need really for supplements. There are all sorts of supplements. All the supplement you need is really vitamin D. Restricting alcohol intake, is there a slide missing? I think, anyway, to around 2 or less units a week. This is the amount of, there's one missing about smoking. Anyway, it's a Van Gogh portrait, which I got from his museum. This is the amount of calcium you need, 700 milligrams, which is not really a lot. And that's the official UK reference nutrient intake. And again, for vitamin D, the recommendation is 400. Older patients or patients on medication will probably need 800 or even 1,000 of that. And the problem is foods. These are where do you get the calcium? Calcium is in milk and dairy products, and in a way, dark green vegetables. The darker they are, the more calcium they contain, and they contain more iron as well. So that's really, in a way, important. Sorry, it's this one. And as I said, we think a problem with doctors and the pharmaceutical industry are obsessed with vitamin D, and they tend to promote vitamin D for the prevention of cancer, prevention of this, prevention of that. The reality is the recent studies from last year showed it does not stop you getting cancer or doesn't stop you, but you really need it for normal bone function. And some of your part of your immune system does need vitamin D, but I think its benefit is exaggerated. Vitamin D food is really very deficient in vitamin D, apart from, in a way, the fish oils. And so people who live in the Eskimo, they do get the same diseases. They do get BEHÇET'S, lupus, rheumatoid, Crohn's, but they have less pain. So if you are on a fish-only diet, you still get the same diseases, but you get less. So they need less anti-inflammation tablets. So you could see that everything is really quite poor in vitamin D. So this is why it's best. And the other problem with people who are fair-skinned is the skin ages and so it becomes a poor maker of vitamin D. Black people, in fact, has the best skin, and their skin is always a good factory for vitamin D, but they need the sunshine. But I think the fairer one is, the poorer the skin becomes as a maker of vitamin D. Exercise. If you ask me, what do? I will only do one thing to live a healthy life or a long life, and that is exercise. There's no doubt about that. If you stop all your medication, or I'm not suggesting that, but in a way, the exercise will lower your blood pressure, will build up your muscles, will build up your bones, will in fact improve your psychological well-being, and it has so many. And any form of exercise, you don't have to lift weights, because what you really need, if you build up your muscle, for example, swimming, you're using all your muscles, but there isn't really much, in a way, weight bearing. However, because you have better muscles, when you fall, you're more likely to protect yourself. And so there you are. It's and the one last thing I need to talk about is the monthly cycle. A woman of childbearing age must, so every doctor, and in fact I asked so many people, hardly anyone asked about the monthly cycle, especially women who look thin, who lost a lot of weight, who are taking more than 15 or 20 milligrams of prednisolone a day, they may lose their monthly cycle. And the lack of estrogen is the worst thing that could happen to your bones. So always make sure that is there. And this is a good example. It's a 32-year-old lady who had anorexia for 5 years. She weighed 46 kilograms. No periods for 5 years. She was taking vitamin D, and I told her really no treatment would help her unless she gains weight, because the critical body weight for a woman is 50. And I'll tell you, the critical body weight for a man, when it comes to the bone, is 70 kilograms. So this lady, eventually, the like of Steve Higgins, treated her well, and she started gaining weight, and her body weight went up to 54, and we did her DEXA scan, and you could see her bones became normal. Look at the amount of bone 779, 940. That's normal, 756, just to show you the regaining the monthly cycle made her bones healthy. And in fact, it made her, she's a new human being. So so that is really terribly important. As I said, in men, it's the body weight. I mean, the three main factors is the age, 75 and over, the bones will be thinner, smoking, COPD, emphysema, bronchitis, but it's the body weight in men. And this is a good example that I was sent this man. He is, they did all the tests, 59 years old, and he was osteoporotic. But the reason, look at that, he only weighs less than 62 kilograms. And again, addressing that, normalize their bone. So keep as active as possible. Take your vitamin D supplement, Greenwich Mean Time. No need for British summertime. So prepare them, not this next Saturday week. Don't drink too much. Don't smoke. And eat well. And as we say in the East End of London, and Bob is your uncle. Thank you very much.
Okay, so I now would like to welcome Dr. Sarah Sacoor, who's a speciality doctor in BEHÇET'S. Welcome.
Thank you. Hi everyone, so I'm Sarah. I'm one of the oral medicine and general doctors in the London Centre, and I also work on the research side. So I'm going to be talking about medication adherence and compliance based off some questionnaires that we've been giving to the patients over the last few years, with some very interesting findings which I hope can help some of you. This looks very complicated, don't worry, but it's just a summary of the medication that is given to patients with BEHÇET'S. So on the left-hand side, you see the treatment for less complex disease. So that will be mouthwashes, ointments, topical treatments, medications such as colchicine, and then the DMARDs such as azathioprine, mycophenolate mofetil. And as disease becomes more severe, going into the organ-threatening disease, so the sight-threatening disease, neurological and vascular, we then move into the biologics, treatments like infliximab. So why is medication compliance important? So it helps to manage the symptoms of the disease. It helps to prevent severe complications, so as Professor Fortune mentioned earlier, the loss of vision, but also blood clots, neurological disease, and it's not good to stop some treatments abruptly. So things like steroids have to be taken continuously, as Hannah mentioned earlier in her talk, having suffered with adrenal crises where your body's not producing enough steroid. So we had a look at 214 patients. The men did slightly better on this one, so we've got 58% females and 42% males. We had a range of incomes, a range of work, although actually more than half of patients were in full-time employment, 15% part-time and the rest either unemployed, students, self-employed or retired. Most of the patients were married with a partner, some single, some divorced or separated, and we had varying levels of education through to school education right up to PhD. So firstly, one of the important things that came across is how important social support is with medication compliance. So on the top left, we asked the patients if they'd been in contact with Jean, our BEHÇET'S support coordinator in London. And there's not a huge difference, but there were slightly more patients who were non-compliant who were accessing Jean's help, which suggests that those who were really in need of social support were struggling with their medication. And then on the top right, we looked at living situations. So patients who were living alone or living with a housemate were more likely to be less compliant, but those who had a partner or were living at home with family were more likely to be well supported and compliant. And then in the bottom, we looked at perceived social support. So do they feel well supported around their condition by friends and family? And those who did not feel supported were more likely to be non-compliant. We also looked at financial implications. Obviously, things are quite difficult, the cost of living, and sometimes priorities might change where you've got to pay bills and cover your housing finances. And the patients who paid for their prescriptions, either through prepayment certificates or paying for individual prescriptions, were less likely to comply. Given all of that, the most important thing for compliance was actually behaviour, so the patterns of behaviour of how medication is taken. So patients who don't take their medication at the same time every day, for example, had problems with compliance and were more likely to miss doses more frequently. And this, so far, has seemed to be slightly more important than the socioeconomic details. There was also a difference between types of medication, and these were some of the comments. So colchicine was quite frequently one that was missed, and that's either due to the prescriptions or the GPs not giving it. Sometimes the GPs are worried about prescribing colchicine, but if we advise it from the London Centre anyway, we will write on your letter for the GP to continue. The triaurosol mouthwash, and that's through being forgetful, being away from home, or having side effects. Azathioprine due to forgetfulness, problems with ordering, problems with getting prescriptions, problem with the pharmacy. Adalimumab, so that's Humira, and that's scheduling logistics, so not the patient's fault always. Mycophenolate mofetil due to forgetfulness and side effects. Being out in the evening for 6-mercaptopurine, prednisolone, forgetfulness, and low perceived importance. So in summary, medication compliance is important, but we do understand that there are so many reasons for forgetting to take medication or not being able to take it, whether it be financial, you're busy looking after the children, you've got a busy job, you're just really feeling awful and not able to take it. But either way, it's really important to let your healthcare professionals know if you're having a problem. We're not going to tell you off, we just want to be there to support you and try and think of strategies and ways to help you so that you can be compliant, so that your disease remains under control. Thank you very much.
So we're going to break a little bit earlier than scheduled. I don't know if teas and coffees will be ready quite yet for those in the room, but we will have a break now until 3. Is that right? Is that like 3? Yeah, 3. What I'm just going to say is for those that are in the room, we're going to be putting evaluation forms on the tables, so please do fill those in. For those of you that are online, the link is going to appear as we come back for the final part of the session. Oh, no, I've just had a word. Gem's going to put it on now. So she's going to put it on now for you. So if you do have time to just give us some feedback of the sessions that you've seen so far, and then obviously this afternoon as we finish up. So break until 3, people back in the room here for 5 to 3 would be great. Thank you.